It's really a pleasure to be here, and certainly as a hematologist talking about bleeding disorders in women, there are certainly experts, including Dr. Phillip and Dr. Quedes in your region, who could certainly give this talk, but I will try my best here. And also the prior speaker, Dr. James, could certainly give the hematology side also. So I thought, what am I going to talk about that she won't talk about, because she could talk about everything that I'm going to say. But here we go. Let's see. Oh, I need to we'll do that later. And you know, there was a great, I don't know if any of you listen to the radio show, Wait, Don't Tell Me, but they visited Seattle. They had this clip on the death of, what's the name of, the death of that Clippy? Yeah, whatever his name is, and it was so funny. And they took him on this trip, and they were taking him to die, and he didn't know it because he kept wanting to help them. And if you ever get a chance, when they do their like best of all time, it always makes it. So what I thought I'd do is I start with a few patient presentations. So the first one, we have a 32-year-old woman with type 1 von Willebrand disease. She has a history of menorrhagia and bleeding with dental extraction, and now she's in her first pregnancy. And in a fortunate circumstance, which we often don't have when we get called about women who are pregnant with von Willebrand disease, we have pre-pregnancy values, and they are consistent with a mild type 1 in that she has an antigen of 35%, a Risto of 34%, a factor rate of 45%, and normal multimers. She has a history of excellent response to DDAVP on past testing, and her obstetrician requests advice for management. We have a second patient who's a 32-year-old woman who has a son and brother with severe hemophilia B, and she's now 36 weeks pregnant with a female fetus. Her prior pregnancy resulted in a spontaneous vaginal delivery, and she said there was some increased bleeding immediately after delivery, but it resolved. A factor IX level drawn 4 weeks prior to this time was 115%, and her local hematologist calls and wants to know if we have an earlier factor IX level, because he wants that to be, he thinks, to be able to manage her pregnancy and delivery. And then we have a patient number 3, a 28-year-old woman who has the diagnosis of von Willebrand disease. And you're told that her past delivery was complicated by hemorrhage requiring transfusion. She also has pre-pregnancy values with an antigen of 35%, but with a ristocetin cofactor with a measure of function that significantly decreased at 10%. She's also mildly thrombocytopenic with a platelet count of 119,000 and has a loss of high and intermediate weight multimers on her multimer evaluation. And so you're asked for advice to this remote hematologist for management during pregnancy. So we'll get back to those at the end. What we're going to talk out first a little about hemostasis in pregnancy, and then pregnancy in women with bleeding disorders with attention more on bleeding complications. And I'll share with you some data from a study we just completed on some women with type 1 VWD, and then hematologic management at delivery, and then we'll return to the patients that I presented. So hemorrhage is, I think, a real force in the response to pregnancy and what happens during pregnancy. And I think these are interesting. There's a lot. I'll point out the important colors here. But this was published in The Lancet in 2006. It was a compilation of reports by the World Health Organization, and they looked at the causes of maternal death in Africa, Asia, Latin America, and the Caribbean, and in developed countries. And what you can see, this big blue piece of pie is hemorrhage and death from hemorrhage. And so in the less developed countries, that hemorrhage remains the major cause, the most common cause of maternal death. And then interestingly, as countries are more developed, it is still a significant but remains but less common cause of death. And then the I thought I had the thrombosis, interestingly, starts increasing. So we're in an area where we get to deal with both the bleeding side in some of our patients and the thrombotic side. And in terms of thrombosis, the hypertensive disease like preeclampsia also become increasingly prevalent. So this force to really push us to be prothrombotic during pregnancy to prevent hemorrhage. And this is a very busy slide, but it's interesting data in that there have been several studies looking at levels of hemostatic proteins during pregnancy. And this is probably the most comprehensive, although they did not test von Willebrand factor, but otherwise it was in terms of what happens for clotting factors. And so in terms of making women prothrombotic, the protein S is a protein that with protein C inactivates clotting, and protein S decreases dramatically. And what is shown here are actually, they determine normal ranges. And as you can see from the beginning of pregnancy, and they did not have pre-pregnancy, and these are cross-sectional studies, that the amount of protein S activity, mostly because of protein-free, markedly decreases with pregnancy. So this is at delivery, and the women have very low levels, and the fibrinogen increases during pregnancy about twofold overall. And actually, women close to delivery have evidence of fibrin degradation with an increased D-dimer. On the side of things that we look at, our women who have different factor deficiencies, factor 1 and factor 5, really don't change much during pregnancy, or factor 2, I'm sorry, and factor 5 really don't change much. They found a little decrease, but when you look at some of these numbers, they're not enough different that it would make us treat women differently. Factor 7 does increase with pregnancy, but that since women with factor 7 deficiency tend to have bleeding if they have really low levels, and you don't really bleed with mildly decreased levels, having a little increase in your factor 7 doesn't help a lot. This study found a slight increase in factor 9. Other studies have not, but again, not really to the point that it helps the woman a lot. Factor 10 also increases a little bit, and factor 8 can increase quite remarkably. Their normal range at delivery was like 131% to 467%. And then immediately after delivery, a week after delivery, up to 521%. So when we think about normal ranges in pregnancy, that's why I think these numbers are remarkable, in that in normal women, these levels get really high. And so I give advice, and we interpret whether our patients will bleed based on non-pregnant normal ranges. But I think we do have to keep in mind that these women may still be pretty low compared to women, normal women without a bleeding disorder. Von Willebrand factor in pregnancy, and this is shows the structure of the von Willebrand factor protein. And the reason I'm showing it, that it's a large protein, and we have these monomers that are made, and then they combine, make dimers, and make these huge multimers, these huge stalks. But the reason I'm showing this is that actually there's a part of von Willebrand factor protein that's cleaved as it's being made, called the propeptide. And the propeptide is this part of von Willebrand factor. And then this part, the real von Willebrand factor protein, is at this end. And the reason I'm pointing this out is I'm going to show you some studies where we also measure this propeptide. So when we secrete von Willebrand factor from the endothelial cell, this propeptide protein is also secreted. And we don't know that it does anything other than it helps the multimers form in the cell. But it has a shorter half-life than the mature protein. So it only circulates for a couple hours, whereas the von Willebrand factor protein that performs the hemostatic function circulates for about 8 to 12 hours. And you may know that we now know that there are patients who have types of von Willebrand. There's a type now called type 1C, where the von Willebrand factor is cleared too rapidly, that a mutation can not only make it so you don't make enough von Willebrand factor, but you can clear it rapidly. And one of the ways we can diagnose that is by actually measuring this propeptide and seeing how the ratio is with the antigen. Because if it's cleared very rapidly, you actually end up having a lower ratio of your von Willebrand factor, your antigen. And that's something we may use more in von Willebrand factor in testing for von Willebrand disease in the future, although it's currently not an FDA-approved kit. So I've been interested in von Willebrand factor a long time and interested in pregnancy and have begun a collaboration. There's a woman, a assistant professor at the blood center, at the Puget Sound Blood Center where I work now, Jill Johnson, who left the same laboratory I did as a postdoc, David Ginsburg, a couple decades after I left. And she's interested in von Willebrand factor, and particularly in carbohydrate modification of von Willebrand factor. And we know that patients with type O blood have lower von Willebrand factor than those with other blood types. And it's really because that these carbohydrate, the blood sugars on the von Willebrand factor, affect how quickly the von Willebrand factor is cleared. So we've been looking with collaboration with a maternal fetal medicine doc, Hilary Gamil, at samples that they have on women without bleeding disorders. And so just to illustrate, and the increase of von Willebrand factor with pregnancy has been reported by a number of individuals, but if you look at the red, these are two samples from 2 women without known bleeding disorders, and the von Willebrand factor increases during pregnancy, and I'll show you some more about how it decreases. And we were interested in, what happens with the propeptide. There was a report from the French years ago saying that von Willebrand factor, the clearance may change in pregnancy. And we actually have been looking at that with the ratio of the von Willebrand propeptide to antigen, and actually we also found in these that it decreased during pregnancy, suggested that there may be a difference in clearance of von Willebrand factor during pregnancy, as well as synthesis. We always say, well, the hormones make us synthesize more von Willebrand factor during pregnancy, and that's why the levels go up. And so it's a kind of intriguing data as that there may be actually a difference also in clearance. And Jill's done some mathematical modeling, and it appears that it may be a combination of an increased synthesis and an increase and a decrease in clearance that causes this increase in von Willebrand factor. So kind of in summary of hemostatic changes during pregnancy, von Willebrand, factor 8, and fibrinogen all increase remarkably. Fibrinogen a little less than von Willebrand and factor 8, but they all have significant increases. Factor 7, factor 10, and factor 12 increase, and then overall factor 2, factor 5, factor 9, and factor 11 really don't change during pregnancy. So a little more on von Willebrand factor, because it's, as I said, a large multimeric protein that circulates in blood, and it stabilizes factor 8. And so it provides those large multimers provide the initial link between the platelet and the ruptured blood vessel, so that generally patients with von Willebrand disease have platelet-like bleeding symptoms, but if they have severe von Willebrand disease, they can also have a low factor 8 and have bleeding symptoms more like is found in hemophilia. And so just looking at clinical manifestations of von Willebrand disease, we've talked about menorrhagia and postpartum hemorrhage tend to be very, very common symptoms. So we just completed a small study. One of the things I showed you the normal range of factor VIII. I didn't show you the normal range of von Willebrand factor in women during pregnancy, but it's very variable. And so what had not been done is actually to take a woman with von Willebrand disease and follow her prospectively through pregnancy to see, well, what happens with an individual rather than doing a cross-sectional analysis of women who show up at different times during pregnancy and having those values from a group of women. And so to be included in the study, the women needed a diagnosis of type 1 VWD, was relatively liberal. They needed to have an antigen erythrocyte cofactor less than 50% prior to pregnancy, a bleeding history consistent with the diagnosis of type 1 VWD, and to confirm a type 1 VWD, their activity to antigen ratio had to be greater than 0.7, only singleton pregnancies, and no additional bleeding disorders. And we enrolled women as early as we could and tested them monthly at presentation for delivery, 12, 24 hours, and 1, 2, and 6 weeks postpartum. And we obtained cord blood if possible, if it did not otherwise interfere with the delivery. And we're actually surprised that we received cord blood on most of the women. Sumi Sood, who's now an assistant professor at the University of Michigan, worked on this with me, as did we had patients by Dr. James Ragney and Shapiro. And this study was funded by a grant from the CSL Behring Foundation when that existed. And so we had 12 women, so it was a small study. They were around 31 years of age. They were all Caucasian. The majority had type O blood. 5 of them, it was their first pregnancy. They had a variable, but all of them did have a bleeding history. They had variable weights, and their values were consistent with their diagnosis of type 1 VWD. And their antigen and erythrocyte cofactors were completely consistent through pregnancy. So they really did look like women with type 1 disease. And here are the values on the women. Some of them we followed longer than others. So we don't have a baseline here. We just have the levels that we got during pregnancy. And what was the most remarkable thing were they all increased, but they all started here between really 25 and 45 with their antigens starting. And they were incredibly variable in terms of how high they went. And one woman had a VWF antigen that went to 240. And we had one woman who had hemorrhage, a primary postpartum hemorrhage requiring transfusion. And it was the woman with the highest von Willebrand antigen level, which I think is the value of research, because had you just taken a history, you would not have thought that the person who needed a blood transfusion, you would have assumed it was the person who had a relatively low level, because some women, although they all increased into the normal range, I think one woman required factor support to get into the normal range. They all did, exception of that one woman, increase into the normal range. Then, as Dr. James alluded to, there's a pretty rapid, it best fits an exponential fall in level, and they were almost at baseline by 6 weeks. But the fall is quite dramatic prior to that. So there's a pretty rapid fall in levels postpartum. In terms of delivery, they all delivered around term. 9 delivered vaginally, 2 by C-section. None actually had an assisted delivery. 7 had genital lacerations, and 7 had epidural anesthesia. There were 1 spinal, 1 general, 1 local, and 1 had no anesthesia. And there were no complications of anesthesia, no bleeding complications of anesthesia. And the estimated blood loss overall, and it would be greater for a C-section, was around 528, which 500 is generally the estimated blood loss normal for a vaginal delivery, and I don't have those broken down, although there was a wide variation. As I said, one woman was transfused, and it was the woman with the highest antigen level, though there were women who received different hemostatics. And the association, though, with increased blood loss was what one would see in general from women without bleeding disorders. A higher BMI being associated with increased blood loss has been reported in the general population, as you would guess, C-section genital laceration or a manual placental delivery. So there were not unique findings, and there was no correlation with baseline levels or with their presentation at delivery. This is back as interesting in terms of this, again, looking to, well, why does von Willebrand factor increase so much during delivery, and what does clearance have to do with that? And so these are just two women whose, this is right around the time of delivery, so this is that presentation of delivery, and then these are hours post-delivery, and the propeptide does not increase as much during pregnancy, and then rapidly falls at 24 hours, which we hypothesize is because the placenta vessels are making von Willebrand factor, and perhaps when you have that loss of placenta. So actually the ratio in these women with type 1 VWD, similar to what we found in women without VWD, decreased to about 60% of their baseline values during pregnancy, and decreased to about 42% of their levels at 24 hours. Then in the cord blood, these are the cord blood von Willebrand antigen values against the maternal von Willebrand antigen values. And you can see that the numbers are different. And so except for this child, all of the children had normal von Willebrand antigen levels, even though the women had lower values, except for this one individual. Now, we only had IRB approval to talk to the mothers. So our history on whether the children had any bleeding complications, and none of them did, were through the mothers. And so according to the mother, this infant was retested by the pediatric hematologist and had normal values and had no bleeding. So we don't know if that was a laboratory issue. But on retest, the infant was normal. So just in this conclusion that the antigen and the function and the factor VIII levels all increased in these women during pregnancy, although very variable in terms of how much they increased. The increase in antigen may be due to both increased synthesis and decreased clearance. This is something we're very interested in, but it could have implications in terms of how we think about von Willebrand factor in pregnancy and how we treat these women. In this very small number, these infants born of women with type 1 VWD had no bleeding complications, and the study is obviously limited by the small size. So we'll switch now to hemophilia, to carriers of hemophilia A and B, or deficiencies of factor VIII or IX. These are, as you know, X-linked disorders, so females are carriers, as illustrated here, and so at risk of having a male infant with hemophilia, or a daughter who is a carrier. Because new mutations are common, it's not unusual to see women who are carriers who have no family history of bleeding disorders, and I've seen that where you refer to a woman who has a isolated low factor VIII, and after you've taken out all the women who it's a lab problem because the tube sat around, you still certainly have women who you diagnose as hemophilia carriers. In women who are carriers of hemophilia, if they do have symptoms, they're usually of mild hemophilia, but not always. And this is data by Carol Casper that's old, that she never published except in she used to do those hemophilia, I forget what they were called. They were great, monographs. And she published this, and I found it, and I don't think it's been published, but these are the number of patients, and this so well illustrates that in carriers, while the average factor level. So the yellow are normals, and these are the number of women, and these are factor A levels. And so you can see in this normal population in yellow, the average is around 100%. But in the hemophilia carriers, and this is factor VIII deficiency, that while the average is around 60%, 2 women were at 10 or less than 10%, and 3 women were at 30%. And so because a woman is a carrier, and also 1 woman was at 110%. And so neither a normal factor level does not show this woman, it will not prove to you that someone's not a carrier. They also can have significantly low levels. And we need to know these things in terms of helping manage these women through pregnancy. Other factor deficiencies, we'll talk about factor 11 a little bit more because it's more common in Ashkenazi Jews, and so we see it more commonly in areas where there are a significant number of Ashkenazi Jews. And they have mucosal bleeding that's variable and may have very mild symptoms. Other factor deficiencies are rare, but I think what we've learned, particularly from the Iranian population and the Italian collaboration, where they have a lot of rare bleeding disorders, that some of these other factor deficiencies, like factor 10 and factor 7, here it is, can be associated with mucosal bleeding. So they can have joint hemorrhage, but they can also have significant mucosal bleeding. Unlike factor 8 and factor 9 deficiency, where you tend to not have as much as much mucosal bleeding. So with factor 11 deficiency, as I said, it's most common in people of Ashkenazi Jewish descent. Mucosal bleeding symptoms predominate. The PTT tends to be prolonged due to factor 11 deficiency, although there's a real question of whether you can bleed it, whether heterozygotes can bleed or not, and that's controversial. Increased fibrinolysis appears to be key. So this becomes a pregnancy issue, though, because generally in antifibrinolytic therapy is kind of a real important part of treatment. And then we don't have concentrates in the U.S. for factor 11, so we replace with FFP. And so this management's interesting. Amicar and tranexamic acid both cross the placenta. And Dr. James pointed out how important fibrinogen is to pregnancy and having a successful pregnancy. So I have tended to avoid antifibrinolytic therapy during pregnancy, although I have to say I communicated with Uri Seligson in Israel, who, because I had an older woman with severe factor 11 deficiency, significant bleeding history, who needed an amniocentesis, was indicated because of her age. She was 39. And to say, well, how do you manage amniocentesis in someone with severe factor 11 deficiency? And so this may be something we could talk about later, those who have experience. I did call a few people, and I didn't, so I thought, well, I would ask him. And I have to tell you, if you ever have a question about factor 11 deficiency, he's incredibly responsive. And they actually use antifibrinolytic therapy around the amniocentesis. They said, do it carefully with a small needle and do not give plasma, but do give 24 hours of antifibrinolytic therapy. So I have not done that, and this person elected not to have an amniocentesis, so we didn't do that. So I'd be interested in the audience, because FFP does carry risks, more actually allergic reactions or or pulmonary lung complications than infectious risk these days. But we do worry about using it, and it puts those women at a special risk. Platelet disorders, I think, are really one of the most challenging. Here's a nice big juicy platelet and some smaller platelets. When we see women as hematologists, we're often asked, I won't talk about ITP, but that's probably the most common condition we're consulted. Certainly abnormal function, the most common are medications, but we see women with with inherited platelet disorders. And like in von Willebrand disease, mucosal symptoms tend to predominate. The autosomal dominant disorders, which are by far the most common, storage pool disorders, these kind of non-specific disorders that we see on platelet aggregation studies that probably involve signal transduction or secretion defects, usually respond to DDAVP outside of pregnancy. I'll be interested in getting Claire's input on how she manages delivery in these women, because I think this is a pretty common, I think we often probably overtreat them, but I think they're one of the most challenging groups to manage through delivery. So I'll ask for her input during the discussion. The autosomal recessive disorders are very rare but very challenging. Bernard-Soulier syndrome, Glanzmann's thrombocythemia, particularly these patients are at risk of alloimmunization. So we want to avoid platelet complex transfusion if possible. Some people use recombinant factor 7A to avoid alloimmunization from platelet transfusion. But it's hard to get them through pregnancy without treatment. And so it's just a really, really challenging situation. I think no one has that many patients that they get much experience with it. I'm going to give you, and this is Claire, neither Claire nor Andy know I'm presenting this, although it's their data, or Peter Coides, but the UDC, as many of you know, there's a female UDC, and that's been piloted, and it has expanded, although we don't quite know what changes are going to come with the change in CDC funding, and so it's kind of a little bit at a standstill, but still recruiting. But Vanessa Byams, who is co-chair of this committee with Peter Coides, put the data together recently, just in the like the usual UDC. For people who aren't familiar with this, it both involves a registration where there's history of past bleeding disorders and then a prospective part. And so Vanessa gave me permission to share a little bit of data. The female UDC began in September 2009. This initial data is from 30 HCCs across the country. As I said, it's registration data, and it includes data through December of last year. And so just a couple slides on this, because it asked lots of questions. It was interesting when this was first piloted. The question was, well, how much time would it add to the HTCs? And the nurses from the pediatric center said, oh, it's a piece of cake, it's nothing. And the nurses from the adult centers like, oh, because it asked every pregnancy, every surgery, every stage of a woman's life. So as you can imagine, if you have someone who is ready for that tubal ligation, like Andy alluded to, there was lots of history. But anyway, most of the women in currently have von Willebrand disease, 88.6%. About 61% of those type 1. Unfortunately, 15.4% unknown. Hopefully we'll be able to sort that out because someone knows their diagnosis. 7.8% are 2 patients, 7.8% with type 2 and 4.4% with type 3. Then the next most common was factor 8 deficiency. This allows inclusion of women with platelet disorders, so they're about 5% with platelet disorders. Then factor 7, factor 9 deficiency, connective tissue disorders, HHT, factor 11 deficiency, PI1, so 2 each of factor 11 and PI1 deficiency, 1 each of fibrinogen, factor 5, factor 10, and factor 13 deficiency. And when we talk about the pregnancy issues, the fact that there are only 2 together with fibrinogen and factor 13 deficiency, this certainly doesn't measure pregnancy issues in those women who do have problems carrying pregnancies to term without replacement therapy. So in terms of the pregnancy outcome, these were 302 pregnancies in 119 females. And so about 68.5% had a full-term delivery. 13.9% had a first trimester miscarriage, and 8% had a preterm delivery. About 6% had a second trimester miscarriage, and 8 women had an elective termination. 4 women had an ectopic, tubal, or molar pregnancy. And I think Andy will probably agree that we probably can't say that any of those are different from what we would see in women without a bleeding disorder, because first trimester miscarriages are very common. I think the interesting thing is the bleeding during miscarriage was the most prevalent, with 76.7%. So this 33 is only of the 43 women with miscarriage. So 33 of them had increased. And if you remember, many of these women had either factor VIII deficiency or type 1 VWD. And I found in those women, it's interesting that they are more likely to bleed with miscarriage than with delivery. And when you think that the levels when they miscarry are likely significantly lower than when they deliver, that would make sense, because bleeding during pregnancy was about 31% and postpartum bleeding was about 38%. And we don't yet have these separated in terms of types, so I can't tell you what happened to the women with more severe von Willebrand disease. So kind of just summarizing inherited bleeding disorders and pregnancy, it's important to know which factors increase during pregnancy. Because in mild VWD and hemophilia A carriers, the levels usually normalize by delivery, but we can't be sure they're going to. So I think it's very important that as Andy advised, that these levels need to be checked closer to delivery. And as I just alluded to, they may have more bleeding symptoms. For those who have levels that increase during pregnancy, they may have more bleeding symptoms early in pregnancy. They're at increased risk of primary and secondary, that's after 24 hours, postpartum hemorrhage, as Andy suggested, an increased risk of a perineal hematoma. And so a collaborative plan for pregnancy and delivery is needed. So what about delivery? So in terms of approach to pregnancy, most are obstetricians, and really I think almost the ruling people often tend to be the anesthesiologists, are happy with levels greater than 50% for delivery, anesthesia, and C-section. In terms of how long we need to treat women, I think is important, and this won't necessarily be long enough. I know Maggie Ragney from Pittsburgh has some experience. They have a large, because they have moderate factor IX deficiency in the Amish population, they have a large number of women who with moderate hemophilia B, and she's learned a lot about managing those women, and she has extended her period, and one of the women said, the last time you really didn't treat me long enough with factor, did you? That she needed to be treated longer. But to remember that in a woman who undergoes a C-section, that's a surgical wound, and that she would need coverage as you would treat someone with hemophilia for a surgical wound. So it really depends on the delivery. I learned from Dr. James that the uterus trumps coagulation. And so, as we've alluded to, at the time of the vaginal delivery, if the uterus contracts normally, that bleeding from the uterus is a minor thing, but if they had a big episiotomy, that's going to be a major thing in terms of a bleeding risk. And so we need to know not only the type of delivery, but whether there are surgical complications around that. That we may need hemostatic products for procedures early in pregnancy, even if we don't need them later. So that in women who are undergoing chorionic villus sampling or amniocentesis, that they may need to be covered early in pregnancy, but won't necessarily need to be covered for delivery. And so we have women return, even if they have factor IX deficiency, which doesn't increase with pregnancy, just to have a value closer to delivery. And then the one risk factor, which I haven't shown you the data, but there's some data, like, well, how do we predict who will have postpartum hemorrhage, and is there a way? And the one which may predict is if they had postpartum hemorrhage with a prior delivery. So in women, even if they have normal lab values with von Willebrand disease or hemophilia carriers at the time of delivery, if they have a history of postpartum hemorrhage, then many people, which I think is very reasonable and I do, will treat them prophylactically initially for postpartum hemorrhage. So just a word, there's some controversy about whether using DDAVP in pregnancy. There's some data on that. It has been, I think it's safe during pregnancy. There's a lot of data on women who use lower doses treated for diabetes insipidus, and they require that it be continued throughout pregnancy, and there are no complications in the fetus. And then a review of the literature by Ray, published in 1998, said that it seemed to be safe for the mother and child. But again, we could need more data, and that it does not precipitate premature labor. And that, as we discussed, that DDAVP can be effective for mild VWD, factor VIII deficiency, and platelet dysfunction disorders, particularly the milder ones. But there is concern about fluid balance postpartum because of the severe fluid shifts, and you can't really restrict that 24 ounces in 24-hour. You can't put that rule in. Again, the interesting thing, though, I think with DDAVP, I have, in women who have responded well to DDAVP, either with mild hemophilia A or type 1 VWD, that we've used it for early pregnancy procedures without problems. So women who amniocentesis, chorionic villus sampling, other issues. One of my concerns, I have given it to women around delivery, and I've not seen a problem with hyponatremia, which you would be concerned with the fluid shifts. I do have concern, though, if I have a woman with von Willebrand disease or who has factor VIII deficiency, if they don't normalize by delivery, I don't have data saying that the DDAVP is going to cause their levels to go up at that point. We tend to not DDAVP test women late in pregnancy, and that it may be a very different. So I would have more concerns, actually, that it might not be effective, that either it's normal and you don't need it, or that they're not normal, and how do we know that actually is going to increase it? One of the challenges is if you use it in patients who have platelet disorders, if they've appeared to be responsive before. So with factor replacement, I think another thing that we need to think about with delivery, it's like a bloody surgery. You can't just give a dose and say the level's going to be fine, because there's a lot of fluid shifts. And so you really, if you have a woman who needs factor replacement around the time of delivery, you need to be able to follow factor levels, and you need to be able to dose for blood loss. And so think of it as a very fluid situation. The platelet transfusions we talked about can be needed for more severe platelet disorders, and non-steroidal anti-inflammatory drugs are the favorite drug of the obstetrician gynecologist after hormones. And so, do you agree with that?
Yes, and I forgot to say hold them after delivery, and all these bleeding women, I put that on my list.
Yeah, so really to avoid that. And then there are, of course, obstetric measures that are taken that Dr. James suggested. And then issues in the postpartum period. So as she described, there's an increased risk of primary and secondary postpartum hemorrhage. And so in women who have a mild bleeding disorder, so that they are normal at the time of delivery, or at least normal by pre-pregnancy standards, I think it's really important that they know that they can have postpartum hemorrhage. And so you want to reassure them that the delivery will be fine, but if they go home and start bleeding, they need to call. And that also I found that the bleeding can go on, and often they're told, well, that you're just a normal variant, and well, it can go on for 6 weeks. You know, you can still be bleeding. And so I tell women, you call me if you're bleeding excessively or if it's prolonged. And they might need a gynecologic intervention, but that I want to know also. Again, to avoid anti-platelet inhibitory drugs, one of the questions in women who have secondary postpartum hemorrhage, so they start bleeding after they go home, is the use of antifibrinolytic therapy. Because the question, and actually I was looking at the package insert for Lystata, which is tranexamic acid, and it says, do not use in breastfeeding. And so this became a question. Before that was available, it was very hard to get information on Amicar, or EACA, as to whether that crossed into breast milk. That and there are some animal models that it does some, is my understanding. But it's and now tranexamic acid are really good medications for women who are having postpartum hemorrhage. And so actually, though, the data for tranexamic acid, there's some data that in breast milk it's 1/100th of the serum concentration. So it's a tiny amount. And so when I talk to my pediatric hematology colleagues, and they would have no qualms about giving that to an infant, I decided, do you have qualms about you're looking at me, giving tranexamic acid to an infant, that in a woman, if it's 1/100th, the serum concentration. But some women, I certainly share that with patients, but it's my feeling that the value to the woman to decrease their menstrual blood flow outweighs any potential risk to the infant. And also that if women have blood loss, we have to remember to make sure they're not iron deficient. So just to go back to our patients, for patient number 1, she had mild type 1 von Willebrand disease. We check levels in the 3rd trimester. We would expect that they would be normal, very normal, and if they are, to reassure and caution. I usually, as probably many of you do, give a letter to the woman, tell her to put a copy in her labor bag, because the obstetricians never have the copy at labor, and to say, give the values, say she should be treated like a normal woman, her values are normal, she can get any kind of anesthesia, any kind of delivery, but because the levels may fall, she's at risk for postpartum hemorrhage, and this is how you contact us if you have any questions. And that doesn't always work for the anesthesiologist, so one of the reasons, although we don't really have enough data because the study was small to do a prospective study, because I've had anesthesiologists say, but can you tell me for sure the levels don't fall between 36 weeks of presentation at labor? And I said, and we have found that they didn't, but it probably still wouldn't convince them, but we try. Patient number 2 has factor 9. She's a carrier of factor 9 deficiency. She has a brother and a son with hemophilia B, but she's unusual in that she has a pretty high level, very normal level. She's having a female fetus, so she could have a carrier, but that fetus should not have bleeding complications at delivery, and she can be reassured that she should not have bleeding complications, and probably her history of initial bleeding was that her uterus didn't contract and they gave her oxytocin and then she stopped bleeding. And then patient number 3 is a woman who has type 2B von Willebrand disease. This is a rare subtype, and it's a particular challenge during pregnancy because they make an abnormal von Willebrand factor that binds the platelet in circulation. So as they make more von Willebrand factor during pregnancy, they become progressively thrombocytopenic. And then during labor, they can become even more thrombocytopenic. So I had a woman who hit 5,000 with delivery, and they definitely require factor support and sometimes require platelet transfusion. Whether it helps that much, we give it. And so this is the kind of woman that you want to be in your hands when they deliver, which brings me to a summary of that bleeding in women. They clearly have, hopefully we convinced you, gynecologic and obstetric challenges, and collaboration with obstetrician, a high-risk obstetrician, is really valuable, and particularly one, it's great working with Andy all these years because she clearly is very comfortable. And I had colleagues at Penn and at Jefferson and now in Washington who are really comfortable with this. And I think for the woman, I had the woman that I presented with the 2B, she had an obstetrician for her second pregnancy. She went to see, who said, well, she will likely bleed to death. And that's not what the women want to hear. So it really helps for them to have someone who has confidence. And so even if you have someone who's had had just a terrible experience because the obstetrician wasn't comfortable with it, that I think that's a reason for them to change care. And as Andy pointed out, the many things with a pre-pregnancy evaluation and a pregnancy delivery plan, and if the woman is carrying or a possible hemophilic infant, as she said, to have counseling. We found it, Regina Butler at CHOP does counseling for pregnant women, and she was a great asset because women, particularly with their first child, their fathers had hemophilia. It's very different than what they face, and so she did a lot of discussion what it's like to have a child with hemophilia now, and that can be very valuable for someone who doesn't know about hemophilia or doesn't know about hemophilia in this age. And they should be vaccinated, and they should refer to the appropriate delivery setting. So one with mild type 1 VWD, you can give advice, and generally it works well. And so, but in women who need factor, then they need to be someplace where we can monitor factor levels, so that there are appropriate precautions and treatment for both the woman and the neonate. As Andy and I did a session at NHF and had a young woman who had a home birth child who had severe hemophilia, was not expecting that, and she very much wanted to have her second male at home, and wanted to know about that.
You mean at your home?
At her home, yeah, no. But we were saved in that instance by all the mothers in the room who could not believe that she would put her infant at risk by having her infant at home. So other mothers saved us from having to counter that. And this is just from Washington State. I moved there, I didn't know they grew tulips. So north of Seattle last April, these are the tulip fields. And with that, I don't have the ending. I thank you.